It's so wonderful to be here. What a treat to be here with you all who are in the field, who are in the community, working and helping shape and sharpen the skills of our students. It's a real treat to be here to talk about and share with you an evidence-based practice approach that the students are learning in the classroom. And so it's a nice way to give you exposure to this practice, because what we've done as part of this federal initiative is we've embedded this evidence-based practice called SBIRT that we're going to cover in great detail today into our curriculum, into the undergraduate psychology curriculum, into the master's psychology curriculum, and into the doctoral level psychology curriculum in kind of various spots of where it fits. We've tried to weave it in. We're still kind of trying to identify which classroom in which setting, because as Sam indicated, and as you'll learn today, SBIRT really consists of 3 evidence-based practices, right? It consists of an assessment piece, it consists of a didactic motivational interviewing, behavioral intervention piece, and it consists of a referral to treatment using warm handoff or motivational interviewing or case management or linkages, right? So there's 3 practices that are encompassed within SBIRT. And so where does that fit in the classroom to give them that book knowledge, to give them that exposure? And what we're hoping to do is to share with you about SBIRT so you can help us too. We'd like to hear from you where it fits in their training, in their setting. Does it fit in your setting? Sam, or it was mentioned here today of direct supervision. This might be an interesting or a good fit for that. And we're going to share with you tools of what we have for you to be able to observe that. We've identified and developed a fidelity worksheet that can be used during observation of your supervisees. Supervisees? Mentees? Yeah, good. So I just wanted to point that out and kind of hook it and contextualize it to what was shared here. So as a way to kick off SBIRT and the importance of SBIRT, and for you to kind of understand the magnitude of SBIRT at the national level in terms of it being a priority, I like to start off with an activity. So you all received a small note card, some pink, some blue, some got the yellow cards. And so if you take that out, right, the red card, we don't have any red cards in here. And what I'd like you to do is engage in a brief activity with us. And what we're going to ask you to do is we're going to ask you to guesstimate the number of individuals in the United States, 12 years and older, who report alcohol and illicit drug use annually. So nationally, SAMHSA conducts an annual survey. So SAMHSA stands for the Substance Abuse Mental Health Service Administration. You're probably all aware of that, so I just need to be mindful of acronyms. So SAMHSA, along with the National Institute of Drug Abuse, NIDA, under NIH, they annually survey the US population to look at trends, right? Epidemiological trends, the scope of the substance use issue in communities. How many people are using alcohol and drugs? And the surveys capture just regular use. A few times they report each year, incidence and prevalence rates. They also capture what they call problematic use, and these are through questions that ask about more frequent use, misuse, binging with alcohol, drinking more quantity or consuming more. They would categorize it as problem use. Then there's questions that help us understand harmful use or hazardous use. This is use that is problematic, it's more frequent, it's daily, and they're experiencing problems. So it's more harmful to, it's bringing impairment in functioning or their ability to go to work the next day or whatever it might be, or impairing relationships. And then the severe category, these are individuals that are in treatment for substance use disorder. So we'll start with the top of the pyramid. And how many, if for those of you in the room, want to take a guess of how many % are millions did you say were in treatment right now for substance use disorders? And by treatment, we mean in a rehabilitative setting, in the community, detox, outpatient, residential. Not in recovery, which would be in Narcotics Anonymous, 12-step, right? That's recovery.
So it'll take a while.
Yeah.
Just 0.5%.
0.5%. Okay. Yeah. In treatment.
So you could be raging drug and alcohol problem and not in treatment, you wouldn't be in it.
That's this category. They need treatment. Yeah. So speaking of that, so you anybody put more than about half? 2%? 1? 3? Anybody put more than that? 4? 10? Okay, 10%. Yeah, no. Yeah. Usually we get numbers that are 20 or 30%. Yeah. And we get these numbers by younger generations. I'm not calling you all old, but. How about this category? You had indicated those that might need treatment, but they're not. So what percent or how many millions did you, or anybody else want to? 12%? 30? 30%? 15? 18? So about 30 or less. Anybody say more than 30? How about this middle part here? Problematic use. We call this unhealthy use. We call this, some people call it social use, just going to the bar after work and having a happy hour. What percent, or how many million? 30%? 30, about a third? 45. Yeah. The younger crowd, we usually get more than 50. They'll take a guess at that. Many of you are fairly close. 30% here, some of you are spot on, and 2% here, 15%, and 10%. So you're actually very close in terms of your understanding of substance use patterns in the United States, which is really good. I'm impressed. Usually there's a lot of variance here. But if you look at any one time from the National Survey on Drug Use and Health, these trends are pretty stable, right? This is 12 years and older. If you look at, we do more specific information on the youth population. The rates are higher among the young adult, the transitional age. 18 to 24 would have the higher rates. Adolescents would have the less rates. So 12 to 17 would be less, the young adult would be most, and then the older adult would follow the young adult. This is general snapshot, and so there are other numbers. And if you look at, this is one way to get at measurement. And if you ask any one person in the US how, the scope of the issue, it's complex, right? Because we can pull data from emergency rooms, we can pull data from treatment centers, we can pull data from health settings, mental health settings, other community settings, and the surveys or the numbers would probably look a little different depending. There's self-reporting biases that you all are aware of. But generally speaking, this is usually the prevalence and the trends. We show this, and this is used in discussions at the Office of National Drug Control Policy, at the federal level with SAMHSA, at NIH, right? And they say, well, what do we do? How do we start to begin, for years, these are the trends. And how do we start to begin to really have a national agenda around prevention of substance use? That's not primary prevention. What is primary prevention? Primary prevention is done in high schools. Just say no. We know people are not just saying no, right? Primary prevention is strategies to get individuals, usually young people, not to ever use alcohol or drugs, right? Or at the SAMHSA or NIH level, at Office of National Drug Control Policy, they put a lot of funds into other efforts, right? Treatment, or interdiction, securing the borders, drug trafficking, right? What they don't do a lot, what they found over time was they really haven't dealt with these individuals, right? They do a lot of this, or they do the ones that are not here, that aren't, you know, they do a lot of efforts around primary prevention. But what has been fallen off the map and in systems has been not addressing general use, problematic use, risky use, hazardous use within settings, within healthcare settings, mental health settings, school-based settings, right? We either do primary prevention or treatment or legal stuff, but nothing in between. And so this has been put on the radar nationally as a big priority around how we do prevention. And they call it secondary prevention. How many of you have heard of secondary prevention, early intervention? That's SBIRT. SBIRT is really a model to identify risk, and they define risk falling along any use, problem use, or harmful use. There's risk. And triage the risk. It might be mild risk. It might be, you know, they're just kind of using it, but we should kind of address it as something that is related to wellness and behavioral health, just like we do with wearing a seatbelt, just like we do with exercise, just like we do with diet. You know, you're eating too many cheeseburgers, your cholesterol is going up. Same kind of idea with this national prevention agenda, where we're really identifying this as more risky, that needs to be shifted into the healthcare conversations in mental health settings, in community clinics, in school settings, as a behavioral health risk, right? Just like diet, just like exercise, that can at any point in time lead to problems. And it is really a continuum. Just because somebody uses alcohol and drugs one time, they're not going to become addicted, right? They're not going to develop a substance use disorder. Over time, though, as we know, substance use disorders are brain diseases, right? Just like mental health issues. They may start off generally, and they exacerbate if they're left untreated, if they're left unaddressed. And so that's what we see tend to happen, and we find individuals that are in these two categories. If you combine this, about 20% are in need of treatment, but they're not. Why aren't they in treatment? Because they're not identified. They fall through the cracks. Or if it is identified, nobody wants to talk about it. It's like, well, you're here to treat your mental health issue. You're here to treat your health issue, your diabetes, your high blood pressure. We're here to address your school behavioral issues, right? So the substance use, although it's always this big elephant in the room, interwoven or probably related or connected in some way, shape, or form to the broader issues, it's usually ignored. It could be addressed, but what happens is providers and professionals are ill-equipped, right? They're not comfortable talking about alcohol and drugs. Why not? Usually. I'm not saying anybody in here, but generally. Why not? Huh? Lack of training, absolutely. Right? With stigma. There's a lot of stigma and shame when it comes to these, right? With just general use, we're in a highly medicated society, right? Just general tobacco use, alcohol use, prescription use, coffee, right? Those other energy drinks, what are those called? Monsters, yeah. However, when it becomes problematic, right, it's usually, there's a lot of denial, like, oh no, I don't have a problem. But then there's shame and stigma. There's embarrassment, there's fear, right? And because it's a brain issue, over time, and they don't even know it, just over time, there's changes that are occurring within their neurological, hormonal balance of the way their neurotransmitters fire, right? And so I think it's a lot of shame, a lot of stigma. There's lack of training. And should substance use come up, there's lack of training on how to kind of talk about it, how to intervene with SBIRT, but there's also lack of information or knowledge on the effects of substances, right? What the various substances are, how they might interact, how they're going to affect someone, right? All of these more detailed information that just kind of like, okay, I'm just not going to deal with that. Somebody else is going to deal with that in the community, right? So it's become a big issue. And so because of that, SBIRT has become a big priority in the country for embedding SBIRT training in the curriculums of professionals that are the frontliners, right? That they are going to be in community settings, in clinics. They're going to be in mental health, social welfare, healthcare settings, churches. We've also, we're hitting pastoral ministry kind of settings, because these are individuals that are in the front line, and usually individuals don't show up for substance use issues because of the shame and stigma. They're going to show up for correlated issues, right? Family problems, child issues, mental health, financial problems, whatever it might be. But more times than not, there's an underlying substance use unhealthy pattern. It doesn't have to be severe enough that it needs treatment, but there's something there that is problematic that usually goes unaddressed. And so that behavior continues because, as you all know, substance use, we use it, and when people do use it, it's for what? For fun, or to help what? Relieve stress, right? It's to help medicate, it's to help cope. I need to take a load off. Just one more drink, right? So it's very correlated. Not that I do that, just saying. So, so why care? For all of you, you know, if I was talking to nurses, I'd probably present some data on how it's linked to a lot of physiological issues like cirrhosis and poor kidney function and diabetes and all sorts of other health issues, sleep apnea, headaches, issues with lungs, right? Cancers. However, so know that when we talk about psychology, and my colleagues are going to talk about the kind of the framework to really use, I wanted to just kind of hit home here for you all in your settings as psychologists and as therapists and as counselors and as supervisors of those students coming into your setting that are going to be fabulous psychologists and counselors and therapists one day. They need to know about substance use because it frequently co-occurs with mental health issues, right? So co-occurring disorders, what % of individuals have co-occurring mental health issues and substance use? If you were to just guess, let's say with depression, what % would you say with alcohol and depression? 60? What about with illicit drugs and depression? A little lower, 30, 40. So 60 is with drug, not alcohol. So this is rates of having any disorder, mood disorder, and so 60, but depression is about 44%, anxiety is 42. Those with a drug use disorder will also report, or not report, but be diagnosed to have clinical issues of depression or anxiety usually. Those are the two top. Depending on what they use, there can be substance-induced issues like psychosis, some other ones that are more obsessive compulsive disorder and some of the other axis 2 issues. But with alcohol too, you'll see the numbers are high with any mood disorder, about 41%, or anxiety 30%. So it's actually more with the illicit drug, just because I think the way they work on the brain and how they're changing the brain alongside the general pattern of mental health issues. So this is important, right? So a lot of what happens in the settings, and I'm working with the Department of Mental Health right now, training a lot of their TAY providers, transitional age youth, because it gets ignored. They're trained to treat the depression, They're trained to deal with anxiety, but they lack the skills and the know-how of how to deal with the drugs and alcohol. So that was, it get brought up, brought up, and it's usually acknowledged, but then not dealt with, right? So, huge issue in our system, particularly in the mental health system. In healthcare, it's there too, but I think in healthcare settings, they're one and done, right? It's quick, you're in and out, you go to the doctor once a year, but in mental health settings and in social work settings and in other community clinics, school settings, they're captive, right, for quite some time. And so, but it usually falls through the cracks due through lack of training. This is something that, another rationale for SBIRT is what they've done is not only do we understand that substance use issues are pretty common, right? Substance use reporting, problem use, risky use, hazardous use, and those in treatment. But for those that are not in treatment, if it's left unaddressed, we do have data every year from emergency rooms, from mental health settings, that collect annually cost-related information, right? Claims, billing. And we do see that there's a lot of interaction with social issues. If you look at homelessness, if you look at school dropout, if you look at poverty, unemployment, and you look at research, substance use is a significant predictor, significant. If you look at violence and trauma, domestic violence, neglect, malnourishment, broken relationships, divorce, substance use is a strong correlate. If you look at the legal system and the percent of individuals that are arrested each year, about 80% substance use issues, right? Violence and homicide and incarceration, substance use is always, usually more times than not, a predictor, a factor in these issues. If you look at public health issues with HIV and STDs and other chronic issues, substance use is always a leading indicator. And then the healthcare setting, if you look at mental health, like we just shared, depression, anxiety, psychosis, there's the other. Mania and ADHD are very common, and conduct disorder, the last one. But suicide, huge national priority effort right now. I mean, annually, but Sam says that's a big effort and it's a big agenda item for the National Institute of Mental Health, NIMH, and SAMHSA. They're doing a big, big campaign on suicide and the relationship with substance use. Not substance use disorders, but the unhealthy patterns, just general use. And so to contextualize SBIRT and why you should care, and you do care, but why you should really take it by the reins and really think about how in your clinical setting as a supervisor, how you can come alongside your students who were training on SBIRT to really allow that to happen. So we've covered this. There's gaps in the system. There's not a lot of training that goes on in medical residencies, in doctoral clinical psych programs, in master's level programs, in nursing or in social work. Professionals have little to no formal training in the areas of how to deal with substance use issues, generally, or when they become a disorder. So I'm not going to use abuse dependence, but generally. So that gets at that secondary prevention, that middle of that pyramid. That's what I would mean as a substance use issue. Because according to NIH, any use of drugs is risk. And it goes back to your point, well, it probably doesn't start off to be risk. The alcohol companies tell us to drink responsibly. But more times than not, people have more than they should be having, right? When it comes to a standard drink, standard drinking units, and how much should you have to reach that level where you shouldn't be driving, or it's going to cause health impairment, right? So that's a huge issue, generally with alcohol. But with any drugs, any use is risk, right? So how do you do with substance use issues as risk? that's where SBIRT, I think, is a really good tool that we're going to expose you to. And then how do you deal with the substance use disorders when they are problematic? Well, if there's no formal training in how to use the referral to treatment, or how maybe you don't have it in your setting there, but how to get them into a community system that can treat them. And we're going to cover that, how to get them to detox, how to get them to a rehab, outpatient or inpatient, that really specializes in that, but then how you can work with them still as they're transitioning to that, but still in your care, right? So how do we do that? And so that's what the RT piece of SBIRT means, really, right? And so it's called integration. The field is really moving towards integration, 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 right? Even though you're not trained, or maybe you are trained, but it's not in your scope of practice to provide outpatient treatment, to provide detox or residential treatment. That's fine, but how you can make efforts to work on integration and collaboration with those settings that can do that for your clients and patients. So nationally, SBIRT is recognized as being embedded within the Affordable Care Act. So there were several changes to healthcare. And one of them was the expansion of Medicare and Medicaid, where the benefit packages under Medicare for substance use wasn't at parity with mental health issues, right? The services that were given in healthcare or mental health settings, or even in the community, were skimpy. What do I mean by that? They were very short-lived, right? You get, 2 days of this, and then you get 2 weeks of that, and you should be, probably 10 weeks, and you should be squeaky clean. You're treated, we covered that benefit, and you should never use alcohol and drugs again. You should be abstinent for the rest of your life. And you should go participate in those AA and NA groups in the community to help you. Although they're not funded, they're just, organized. They'll go help you deal with your craving. Right? Very broken system. And so under healthcare reform, what was done was they've expanded the benefits, right? So medication-assisted treatment got added. Case management got added. Aftercare, recovery support, not NA or AA, but aftercare, where they would be discharged from an outpatient or residential setting and followed or given services for 6 months to ensure they're working on self-management, on their craving, right? And so this is exciting for our field, although it might get blown up under the new bill. So right now, though, we do have SBIRT as a national priority. It's recognized by changes to the Medicaid. In California, that's Medi-Cal, right? And so it improves access to these services that otherwise weren't available, that I just talked about. So what is SBIRT? It's an acronym. But like I said earlier when I opened up, it is a comprehensive, if you will, approach, right? It's an approach that consists of 3 specific strategies that are all billable under Medi-Cal, under healthcare reform. Screening. Screening is another way or form of assessment, right? Screening, though, is not assessment, and something to be mindful of. So screening for SBIRT, when you're using it within an SBIRT context, screening is supposed to be very brief through a set of questions that have been validated to pick up risk. Not just any open like, oh, you're using alcohol and drugs? Right? No, there's been a lot of effort and research around identifying the items in these screening tools that crosswalk with DSM-5 around consumption impairment to then detect potential risk. So we're going to cover those later. Those are in your packets, the screening tools that have been validated and that you can use and get reimbursed for. There's validated screening tools for adults, and there's validated screening tools for adolescents. So we'll cover those in a bit. So that's screening, and it's screening to identify the risk for alcohol and drug use patterns, not assessment. You're not taking life history here. So tell me when you started using drugs. How old were you? Does your parents use? Right, all of that stuff that you do in assessment, which is great, but that's when, if they screen for high risk, you would then refer that RT for further assessment. And that's when you'd be able to fully engage in a DSM-5 assessment. Should risk come up, and the screening tools are really useful because they do put them like that pyramid. They'll put them at a low risk level. It's like, oh, well, they just generally were using, nothing to kind of write home to mom about, but something to put on their radar that I'm going to bring up and have a conversation about. Or there's more moderate risk where it's like, whoa, you need to think about putting on some brakes here, making some changes. Or that severe risk. The screening will put them in those patterns, then for that practitioner to be able to know, are they mild, are they moderate, are they more severe, to then triage the risk appropriately and not treat them all the same, right? Because some might be having more issues than others, and so that's, SBIRT is very individualized. It's very unique. It doesn't treat them like a one-size-fit-all model. It uses a brief intervention, and this is probably the bread and butter, right? And this is used in healthcare settings, it's used in mental health settings, it's used in households if you have small children. It's used with marriages, right? It's a conversation. You're communicating something that might be problematic or bad for someone. And you want to get them to think about, you want to get them to know it, so you're raising awareness, providing feedback, so that they know and they make the choice, right? So you're simply bringing it up. You're not telling them what to do or how to do it, but you're having a conversation using behavior-based principles of behavior change, which is motivational interviewing, right? That we're going to talk about in a bit, where you're going to kind of meet them where they're at. Hey, you're identified to be at risk based on this screener. Tell me about it. Let's talk about it. Do you know you're at risk? Do you know how much you're drinking or how much you're using and you're being put at risk? You do? Okay, great. I just wanted to bring that up. That's the brief intervention. It's a conversation. You'll hear more about that later. And then the referral to treatment. This is when there's high risk or maybe moderate risk, depending on the screener and depending on your conversation during the brief intervention. Something might come up where you're like, I really think this person would benefit from a further assessment. This is where you do integration work. You either refer them to a colleague, maybe within your unit or a setting that might be able to make a further assessment. You might actually yourself take the steps to then do a full-on assessment using DSM-5 to go through those criteria to then make that referral if needed, right? So depending on scope, but SBIRT as a tool allows you to at least start to begin to identify risk, explore risk, and triage it versus just completely ignore it or not know what to do, right? So that's SBIRT, and together the goal of this national prevention agenda is to prevent or reduce the full-blown substance use disorder or get them to a place to kind of start addressing it or in a setting that they can at least talk about how they can address it. We can't force anyone into treatment, right? And usually that's the issue with substance use, right? There's a lot of denial, the shame, the stigma. So it's easy on paper, but once you start doing SBIRT, we got to be mindful of, are they motivated? We're going to talk about this later. Stages of change will. More times than not, they're in the denial, pre-contemplative, or contemplative. Yeah, maybe I will. Maybe. Not now. Thank you for letting me know, right? So substance use issues, just so you know, and we're training the students to know that it's easier said than done, right? To really be mindful of the motivation and stages of change, as well as the shame and stigma, and to really break down those barriers to shift it into a healthcare context. So what we're going to do is what we thought would be useful is we're going to watch a video. so you can see SBIRT in practice, and then we're going to break down the practices. And we just thought we're taking this approach, we feel like it might be helpful. We usually save the video for last to see it all come together, but we wanted to kind of include it early on so you can see SBIRT from a psychologist with an adolescent who is resistant. So the brief intervention, just to let you know, another thing about SBIRT that is very useful for the systems, for mental health settings, for healthcare settings, community-based settings, schools, is there's a protocol. There's steps. That's the other scary thing, like, oh, if they say they use drugs, what do I do? Like, how do I triage it? Do I just say stop? Like, oh, I'm gonna tell your mom? Like, what do we do, right? And so it's called the brief negotiated interview. It was developed out of Yale and shown to be really effective in terms of these steps as a roadmap for really guiding the practitioner who is not used to dealing with substance use. So you raise the subject, is step one. Step one and step two are kind of combined, where you kind of raise it. Given that it's shameful, stigma, you can get arrested. There's a lot going on with alcohol and drugs, right? You want to be mindful of those kinds of things, so you want to raise the subject like, you just filled out a screener. Can we talk about that? Versus, we're going to start talking about your alcohol and drug use. Oh, whoa, no, I didn't come here for that. I came here for my anxiety. Why are you even doing that, right? So just kind of, and normalizing it. You raise the subject and you normalize it. Something we do here, it's routine practice, just it's a health issue that we just want to kind of cover and make sure we're covering that. And then you provide them feedback with what? With their screening score. That's the utility of those screening tools. They're evidence-based, they're validated for giving a score of risk. Low, moderate, or high. You show them that. Just like you go to the doctor and you take your temperature or your weight, there's an objective number, right? That the patient is saying, well, here, look, you're 120 over 80 is normal. You're 140 over 60 or 140 over 100. You're at risk here. What do you think about that, right? So showing them their risk through a number, and it's personalized. It's feedback to them of where they're at. And then you're going to engage, step 3 and 4 kind of combined, where you're going to talk about using MI strategies, this brief conversation, like, tell me about your use, and you're at risk. Do you think you can reduce your use? Do you think you might need to go to a further assessment? You negotiate a plan for that, right? So you use MI skills to get them to do that. So let's watch a video, and I want you to write down MI or examples of MI, either strategies or maybe techniques in the conversation, what you notice about the therapist and then what you notice about the kid or the youth, senior in high school.
All right, Justin. Well, thanks for sharing about what's going on with your family. Sounds like there's a lot of tension in the house, and you're kind of stressed out about it. If it's all right, I'd like to switch gears a little bit and actually talk about your drinking. Would that be all right?
Sure, yeah.
Okay. Well, actually, we, with our, every new person who comes in, we do a screening, and it's an alcohol and drug screening. Do you remember filling that out when you came in?
Yeah, the paperwork at the beginning, yeah.
Yeah. And this, I want to reassure you, this is a normal part that we do with everyone who comes in here to our clinic. And I know it can make people a little bit uncomfortable to talk about drinking or drug use. And so I just want to reassure you that everything you share here is kept confidential. And what that means is that even your parents won't know what you say here unless you share something about you being a risk to yourself. Would that be all right if we talked about it?
Yeah, all right, yeah.
Okay. So on the screening, you indicated that you drink. Can you tell me a little bit about that?
Yeah, I mean, I've been drinking for a couple years. It's mostly with just friends, at parties, on weekends only.
Sure.
I mean, we have a lot of fun. I think that drinking helps, deal with some of that stress I mentioned earlier. And then also, like, it helps me more social, sort of, kind of, like, with my friends. Helps loosen the vibe at the party and stuff like that.
Yeah.
So, It's one of those things that I just really enjoy for the relaxing kind of part of it.
Okay. So
Yeah.
you enjoy it mostly on the weekends.
Yeah.
You hang out with your friends and drink and helps you have a good time.
Yeah. Yeah.
Okay. Great. Thanks for letting me know. I want to let you know that we look at alcohol and drinking as a health issue. We know that kind of like blood pressure and glucose levels can be markers for your overall health and your well-being. We look at your drinking in the same way, that there's levels of risk with drinking, that there's levels of risk that are no risk, and then it moves all the way up to high risk. And so with your screening, you scored a 4. Now, according to national guidelines, that actually puts you at the moderate risk level.
Mm-hmm.
What that means is that with your drinking, you, based on these national guidelines, many people who drink at this level have encounter moderate problems in terms of their health or well-being. What do you think about that?
I mean, I get why they're saying that. They probably have their reasons, but I don't think risk is the right word. I don't see it as a risk for me. I don't. It's because it's just me and my friends. You know, we don't do anything crazy or stupid, really. I normally don't drink till I'm like really sick. I don't do anything. Me and my friends don't do anything crazy and stupid. It's not like I'm getting in trouble. I've had no trouble with the law or anything like that.
Sure.
So I don't know if risk is the right word.
Yeah,
So.
you're not drinking extreme amounts. You're not getting in trouble with the law. You haven't gotten arrested. So you don't feel like you fit with this moderate risk level.
Not really. Yeah.
Okay. Well, yeah, I appreciate you being honest, and I know that what I try to do is I'm not here to lecture you or to tell you whether you should be drinking or not. Actually, my role here is actually to help you figure out where drinking fits into your life and whether it might be contributing to some of these problems you talked about earlier with your family and with stress. And so, would that be all right if I help you think about where drinking fits into your life?
Yeah, sure. Why not?
Okay. So we actually do something. It's called a decisional balance worksheet.
Okay.
And what I'd like you to do is just take a minute and think about some of the good things about drinking.
Thank you.
And maybe some of the not so good things about drinking.
So just fill it out kind of thing?
Sure.
Okay, well, I mean...
And start with the good things. What do you enjoy about drinking?
Okay. I think it helps me socialize.
Okay.
As I said, the vibe of the party. That's always fun.
Mm-hmm.
And then sometimes if the party is, really well or whatever, and I meet a girl, it keeps me from being lonely that night. So that's nice. I don't know. I mean, it helps me relax. Helps me forget about my parents always bagging on me all the time.
Sure. Yeah.
I don't know. I mean, I think that's about it. I mean, it's the socialization.
Those are big things. Just having fun, enjoying the vibe of the party, relaxing, feeling not so stressed with the parents always being on your case, being able to meet girls and hook up with them.
Yeah.
So, those are some of the things that you find pretty good about drinking. Is there anything that's not so good about drinking?
Well, I mean, there's obviously hangovers every once in a while.
Sure.
Those are annoying. And especially, I think, honestly, it would be, I think hangovers on, like, Monday morning.
Mm-hmm.
Those are never good because I'm up at 6 in the morning for school.
Ooh,
So, yeah, hangovers, Mondays. And then, if I'm busy drinking on the weekend, I mean, I guess, one of the things my parents bag on me about would be the fact that I'm not studying. And so my grades aren't quite what they could be.
Okay.
I mean, yeah. I mean, it does. I don't know, but so yeah, the grades kind of affected, and then, you know, on the subject of school, not a lot of people look at, you know, drinking as a positive thing, and so my, you know, friends list is kind of limited, I guess. I don't have the best reputation around the school. People just kind of know me as the guy who parties and drinks, and it's, you know, so it's not the greatest reputation.
Mm-hmm.
And
Okay.
obviously that also is with the way my parents don't, because they're always bagging on me. I just feel like they don't like it at all, and I don't like arguing with my parents. I don't like having my parents, you know, yelling at me all the time about this.
Sure,
so.
yeah, right. So just having them on your case about the drinking is not so good thing.
Yeah, and then, I mean, obviously the booze aren't free, so I have to borrow the money from my parents, you know, wallets and purse and whatnot. So without them knowing. So
Okay,
it's,
right.
yeah.
And it sounds like you don't feel so great about that.
It's not fun because I mean I know my parents work for that money obviously, and but you know, but I like paying for my friends. You know, my friends, I feel like more like generous. It's nice to feel generous.
Yeah,
You know?
right.
Yeah.
Able to buy drinks for everyone, and you're the popular one at the party.
Exactly.
Yeah.
Yeah.
Well liked.
Yeah.
Okay. Was there anything else that's not so good?
I don't know. Other than, I mean, yeah, grades. It's kind of, you know, expensive. Reputation. I mean, those are not helped by that. I get that, but I mean, other than that, I think that's about it.
Okay. So if I gather what you said, there's some good things about drinking. You enjoy the vibe, you enjoy the party atmosphere, being able to hook up with girls. You enjoy being able to relax, to let some of the stress off.
Yeah.
But on the other side, you also feel that you obviously don't like the hangover, and the hangover can be really bad those days you wake up on Monday mornings at 6 o'clock. You also don't like that it's kind of bringing down your schoolwork and you're not able to study.
Yeah.
And you also said that you don't like that you have to take from your parents' wallets, which you feel kind of bad about, it sounds like.
Yeah. Yeah.
Okay. And so did I about capture that, how you feel?
Yeah. That's about it.
Okay. So it sounds like you see some good things and not so good things about drinking. What do you make of all of that?
Well, I feel like I know people have always been telling me that it's a big problem, and I mean I guess it does, you know, have some drawbacks, but I feel like it's, you know, it would, I understand the benefits if it were to not be as prevalent in my behavior.
So you've thought about reducing your drinking?
Yeah, occasionally I kind of, yeah, like in the mornings I wake up or whatever, and it's just like, ugh, this could have been, you know, it could have been avoided, kind of thing. And it's just, yeah.
Yeah. Now, we know that can be a difficult thing to do, to reduce your drinking. To change your behavior in any way can be difficult. And we know that people can vary in terms of how ready they are to change. We know that obviously some people are not ready at all, where they don't want to change and don't see value to it. And then there's others on the other end of the spectrum where you can be absolutely ready to change and feel like you must change. But most people actually find themselves in the middle, where there's some place in between that range. And so what I have here is kind of an illustration of that. That some people are 1, they are not ready to change at all, and others are at 10 where they're absolutely ready. So seeing this ruler, where would you put yourself on it?
I don't know. I mean, I guess maybe I could shoot for 4. A 4, maybe. Yeah, 4.
You feel like you're a 4, maybe a 3 or 4?
Maybe, yeah, like a 4 is a lot. Yeah. I mean, yeah, maybe 3,
Okay.
somewhere in there. Yeah.
Okay. So you put yourself as a 3, that you're somewhat ready to change. What makes you put yourself there instead of a 1?
I guess because, I mean, I think it's, I don't know, because I think, honestly, my reputation is important to me. Like, what others think about me is really important. So I guess the reason for the 3 would be I don't want my parents always, on my case about it. And I don't want to be, I don't want to have a negative, reputation with people at school. So yeah.
Okay. So you've got some readiness to change, and particularly because you want to work on your reputation at school, and you also just don't want your parents on your back all the time.
Yeah.
Okay. Well, great. So, given that, what steps could you take to reduce your drinking? And again, we're not talking about not drinking at all. In this case, you can actually just cut back your drinking if that's what you think would be best for you. And again, I want to highlight, I'm not here to tell you what to do. I'm just here to help you think about what you would like to do in order to just make sure you're taking care of yourself.
Yeah, I understand. I mean, well, I guess it's possible I could just not drink on Sundays. I mean, generally Sundays are not even, and it's not a party day, obviously.
Sure.
So I could just not drink Sundays, completely.
Yeah.
Yeah.
So that makes a lot of sense, to stop drinking on Sunday. Then you'd be able to study on that day, where your grades might come up a little bit, and you'd
No hangover the next morning.
absolutely, you'd
Yeah.
definitely not have that hangover, and that would be great to be able to wake up at 6 and not have to deal with that.
Yeah.
I imagine, and
Yeah.
and then you'd also just have one more day where you don't have your parents always asking you about what's going on, and so I see that making a lot of sense.
Yeah.
Okay.
Yeah, I hear that.
Yeah, and so since you've got some readiness to change, how do you feel about possibly trying out just temporarily? Again, this doesn't have to be permanent, where you just possibly give up drinking on Sundays. Would that be something you'd be interested in trying?
Yeah, that sounds fine. Doesn't sound like too hard of a task. I mean,
Sure.
yeah, I could try that. Yeah.
Well, I mentioned earlier that this change, and really any change, can be very difficult. And so I'd like to figure out how to make sure that you're successful with this. And so I was wondering what kind of resources you have in your life to help you succeed. And I guess first of all, I'd like to know, is faith and spirituality important to you?
Yeah, actually. Me and my family, we go to church every Sunday. And yeah, and I like going. I believe everything they say, and but I don't find myself living by it that often. So yeah.
Yeah, so it's important to you, but your drinking really doesn't fit in with your faith right now.
No.
Yeah.
Yeah. Sometimes the sermons or whatever kind of talk about that kind of stuff, and I kind of feel guilty. So yeah.
Okay. Yeah, and that's not a good place to be. What I'd actually like to see is your faith actually being able to help you with this problem, not just making you feel bad. So is there any way that your faith or spirituality can help you with this problem?
Well, Actually, yeah. At my church, there's like small like youth group, small groups, you know.
Yeah.
And a lot of people get together during the week and we talk about our problems, and I've heard some of the problems of that group, and they're similar to mine, you know. And so I feel like if I were to go there, I would fit right in. So I guess that would be a good environment to help.
Okay, sounds like you can really be honest there, and they're really supportive and would be willing to help you with this.
Yeah, for sure.
Great, yeah. So I think it would be definitely part of our plan for changing this to include going to this youth group and sharing a little bit and seeing if they can help you with making this change and just being a support too.
For sure.
Okay. Well, we always know that any change can be difficult, and so I don't want to underestimate it, but it sounds like you're ready to make that change. And so
Yeah.
I think that makes a lot of sense for you. And
Okay.
based
Yeah.
on what you said, that could definitely help your overall just feeling better and you're accomplishing your goals in life. So great. Well, would it be all right if the next time we meet in about a week, if I bring this up with you and see how you did with your being able to follow through with this and not drinking on Sunday?
Yeah, for sure. Next week, I'll let you know. I'll keep you updated.
Okay.
Yeah.
Okay. Well, that's about it for our time today. It was
Okay.
great to meet you, and I appreciate you being so open and honest with me. Look forward to seeing you in a week.
Sweet. All right.
Okay.
Thank you very much.
All right.
Thank you for your time.
Yeah, absolutely.
We like to show that because that's in a psychology setting with a clinician who I think can do justice to SBIRT, can spend more time talking with their client about generally, right? But as you notice, it went lengthier than like 5 minutes. SBIRT's supposed to be brief, right? 5 to 15 minutes. I think this range like 17 minutes. So it's still within that context, but I think that the clinician spent a lot more time doing MI because of his client, right? So what did you notice, some MI skills or the communication? What did you jot down that you liked or things you didn't like or non-judgmental?
Was matter of fact, very easy going about it.
Yeah. Sitting there just probably squirming like, I want to tell you what to do right now, but I'm not. I want to kind of just shake you, right? Bite my tongue. Okay. Rolling with resistance.
Great job. There wasn't a lot of resistance, but if you know, they will kind of utilize that to reframe it in a positive way
Yeah.
address that for the client.
For the client. You know, I do think with adolescents in particular, so Brady's a senior, he'll be a freshman here next year. And when he said risk, no, I don't think about it as risk, right? Total resisting, you know, the therapist and what he's saying. And at that point, it's like, whoa, you know, what do you mean? You know, it can kill a conversation, you know, a lot more times than not. So he did do a good job rolling with that and rolling with a lot of the you know, just the talk, you know, a lot of chatter, but he did do that well. Starting with the positive, you know, and in it, that's a good point. In motivational interviewing, particularly using the decisional balance tool, which is one of the exercises that is very useful in the brief intervention, because they start with, tell me what you like, versus usually clients are used to being like, uh-oh, they're going to tell me it's bad and it's bad for my health and I'm in trouble, right? But it's like, oh, you want to hear why I like it? And affirming that. Right? Okay, you said this. But with MI, they want you to spend time more so, and I think he did a good job around this, in the quadrant where it's like, tell me about the not so good things. Anything else, right? And he asked that question to make sure, oh, well, there's also this, right? Getting them to think about it and spin those wheels is very different, and who knows what will come out. Sometimes it may be something like, no, nothing. You know, then you're going to get that really resistant person. So there's not a one-size-fits-all model, but MI allows you to work with clients in that respect. But starting with the open-ended questions of what you like is effective, we found, with the brief intervention. Yeah, you know, and being okay with like the quietness, right? It was like quiet for a while, just like, what are you gonna tell me? Yeah, and having them identify it in their own words. And so Curtis and William are gonna talk about motivational interviewing in a bit, and we're gonna talk more about that, but the techniques of open-ended questions and listening, reflective listening, are key with the brief intervention. It's a conversation where we're asking the questions and we're listening. We're not telling. There's one point where he's like, I'm not here to tell you what to do. You know, it's your decision. I'm just raising your awareness about it, or trying to get you to a place that makes sense for you, right? So that was key. Hone in on that. Yeah, that's a good point. You know, and where, you know, as clinicians, to put on those hats as to what you want to pick up on and hone in. And I think within settings, that's something like that you can do. You can drive it and take it where it makes sense, or you know what, I'm not even going to go there because it got killed or shut down. So, but the values is a big piece, and really, the emphasis is getting them to do change talk. And usually personal values and really asking about values will help that, versus pros and cons. The cons aren't typically enough for them to be like, yeah, I think I need a change. You get ambivalence. Yeah, that's a good observation. I love that moment where he met him where he was at. He was a little squirmish. He's like, well, are you sure? Maybe you mean a 3. And like, well, that's okay, I could be lower. And when you expect, well, why aren't you a 10? Well, let's get you there. Let's work on getting you there. He was like, well, why didn't you pick the lower number? And this is a very important, I think, strategy in MI to really hone in on, that can be particularly useful with those that aren't ready for change. And more times than not, if you think about stages of change, even with diet and exercise, we're not. We have time impediments, we have comfort, you know, we're not really realizing it's a problem. So we need some time to think about it. But it is the uniqueness of making them go a little bit deeper with that change talk to really reinforce it and hit it home. Yeah, absolutely. Good. So SBIRT has really been taken in California. Federally, you know, it's under healthcare reform, and different states can opt in to participate in the Medicaid changes. California was one of them. In 2014, they changed the Medi-Cal beneficiary package, and they turned on reimbursement codes, right? So there's not every state in the country has done this. Most of them have, and the benefit looks a little different in each state. But in California, it is part of the Medi-Cal beneficiary, so SBIRT should be given to all beneficiaries 12 years and older in settings. And who should do SBIRT? Licensed practitioners, right? Who can really do MI. Licensed practitioners more so. There are non-licensed healthcare mental health staff that can provide it, but they need to be supervised by a licensed practitioner. So health educators or health coaches or medical assistants, you know, they can do it, but to get reimbursed, you need to be licensed or supervised by a licensed staff for reimbursement. But if you didn't do reimbursement, if you want to take this to churches or community-based settings who don't reimburse or take that in, it could still be done, you know, in SBIRT. SBIRT can still be done, but there wouldn't be any payment. So there are those cases. The other requirement in California, in order for a provider or a practitioner to do SBIRT or supervise SBIRT, they need to be trained for billing in SBIRT. And the state requires, so here's the codes. In Medicaid, it's $48 for a brief, up to 15-minute intervals, the brief intervention. There's screening. You can bill for a screening. In California, the rates are a little higher in DMH, Department of Mental Health, for screening, and the brief intervention. And in California, you can do them up to 4 times a year, screening and the brief intervention. with your clients. The training is a one-time requirement in California. So right, you go, and the training is 4 hours, right? It's a California requirement in order to provide or be supervised in these settings. And you get a certificate. So our training that we developed, all of the students that you supervise, well, hopefully, most of them have went through the SBIRT training. It's an online where we've embedded it in the curriculum in classes where it makes sense. Sometimes it's in the practicum before they go out to their placement. Sometimes it's in assessment classes, it's in counseling classes. As you saw, it can fit in a variety of places. And so the training, we've put it in the disciplines of psychology at undergrad to grad level, social work, undergrad, grad, and nursing, undergrad, grad. And students take the training, and it's a web-based training. You can all take it, and you can go there and interact with it, and we encourage that. It's www.sbirtfaithandspirituality.org. And this certificate of completion that they get, they can download it. It is certified by the California Department of Healthcare. So it meets their requirement. They reviewed our training. It does cover the essential competencies that they would need to be able to conduct SBIRT. Also for supervisors, you can go on, even after today's training, you are going to receive CEUs for this training, but you can do additional training, and it gives you 4 hours of CEUs. You can put your license there, and you can download your certificate. What we've done in our training is we've integrated SAMHSA. We told SAMHSA, since we're a faith-based university, we want to stay true to our roots, and we really want to take this evidence-based practice, and we want to integrate and leverage in a cultural framework, right? And SAMHSA is all about class standards, cultural, linguistic standards, right? Where we really want to adapt it and make it sensitive to race and ethnicity and gender. And we said, well, we want to make it sensitive to faith and spirituality. And we really want to leverage in how faith and spirituality might play a role with somebody's use of substances or change or seeking care, right? And does it leverage it? So we told SAMHSA we were going to integrate spirituality and religion broadly into the modules and into the training. And so what we thought we'd do is we'd integrate that live here for you. And so we have, we're going to take a break, right? Stretch. We're going to change speakers. We're going to hear next from Drs. Lehman and Whitney, who really were instrumental in this training initiative last year and continue to be so with engaging in the modules to really develop material and training for students that effectively leverage in the framework of faith and spirituality within MI. You know, how does that look when they're doing the brief intervention practice in particular?